Hello, this is Dr. Jenny Taylor, Associate Professor of Neurology and Neurological Surgery at the University of California, San Francisco. And I'm here today on behalf of my co-authors to discuss our book chapter, Epidemiology of Brain Tumors. For today's presentation, we will follow the following outline. First, a discussion of classification, incidence, and survival of gliomas by WHO 2016 classification, a discussion of the distribution of adult primary brain tumors by the CB-Truss histology, the annual average age-adjusted incidence and survival for gliomas and meningiomas by CB-Truss histology, genetic syndromes associated with glioma development, and a summary of key germline risk factors for the adult glioma classification, genetic risk factors for meningiomas and other central nervous system tumor development, as well as a discussion of environmental, demographic, and developmental risk factors for both gliomas as well as meningiomas and other CNS tumor development. In 2016, the World Health Organization significantly updated and reclassified multiple CNS tumors. Of note, classification of meningiomas only underwent a minor update with inclusion of brain invasion as criteria to meet atypical or grade 2 meningiomas. However, adult diffuse gliomas underwent significant reclassification. There was incorporation of histology with molecular features, such as key prognostic factors of IDH mutation and 1p19q co-deletion, in order to generate an integrated molecular diagnosis. As displayed here, adult diffuse gliomas are either classified as astrocytomas or oligodendrogliomas. All oligodendrogliomas are felt to carry both the IDH mutation and co-deletion of one of the arms 1p and 19q. However, astrocytomas can further be classified into glioblastomas versus anaplastic and diffuse astrocytomas. Glioblastomas can further be characterized by either the absence of the IDH mutation or the presence of the IDH mutation. Similarly, for the anaplastic and diffuse astrocytomas, these can further be characterized by the absence or presence of IDH mutation. Knowing that IDH is a key molecular prognostic factor for gliomas, this helped homogenize the presence of these different groups, as seen here by the Kaplan-Meier curves. In conjunction with the reclassification in 2016, multiple different groups have also identified additional molecular markers, which are included here. Some involved in the alteration of telomerase, such as TERT and ATRX, as well as different classifications based on TERT, IDH, 1p, and 19q, as displayed here, and alterations in methylation patterns, which also can further classify tumors. This was used with permission from the Nature Neurology Review article published in July of 2019. This is a distribution of adult primary brain tumors by CB-Truss histology. Of note, this is based on the WHO 2007 classification, as data is not yet available for the WHO 2016 classification. As is evident, meningiomas are the most common type of primary brain tumor and account for 42.6% of adult primary brain tumors. Collectively, gliomas account for almost 30% of adult primary brain tumors, with glioblastoma the most common glioma subtype at 17.7%. pilocytic, diffuse, and anaplastic astrocytomas, as well as other unique variants, are a much smaller proportion. And similarly for oligodendrogliomas, both grade 2 and grade 3, ependymomas, and other rare, otherwise not classified gliomas. Other tumors account for about 10%, and pituitary tumors are actually fairly common at 17.8%. This slide depicts the annual average age-adjusted incidence rate for gliomas and meningiomas by CB-Trust histology. Each panel represents a different histology: meningioma, glioblastoma, oligodendroglioma, both diffuse and anaplastic, and astrocytomas, both diffuse and anaplastic. The y-axis depicts the annual average age-adjusted incidence rate per 100,000 people, and notice the markedly different scale for meningiomas and glioblastomas versus oligodendrogliomas and astrocytomas, indicating a much higher incidence in the population of meningiomas and glioblastomas. The x-axis is divided, the population is divided by age. It is evident that for meningiomas, glioblastomas, and astrocytomas, that the annual average age-adjusted incidence increases with age. Females are depicted in pink and males in blue, and it is evident that meningiomas are much more common in females with a ratio of 3:1 versus glioblastomas, oligodendrogliomas, and astrocytomas, which all carry a slightly male preponderance of 1.6:1. Familial genetic syndromes associated with glioma risk are rare and account for a small proportion of cases. Neurofibromatosis type 1 and type 2 are both associated with increased risk of developing astrocytomas, optic nerve gliomas, and ependymomas. Tuberous sclerosis is also associated with increased risk of developing astrocytomas. Lynch and Lee-Fraumeni syndrome are associated with increased risk of developing glioblastomas and other gliomas. And Olier's disease, associated with germline mutations in IDH1 or IDH2, are also associated with increased glioma risk. This slide summarizes germline risk factors for the WHO 2016 adult glioma classification. GWAS studies identified 25 risk SNPs for gliomas. Each box represents a WHO 2016 glioma subtype. Overlapping boxes contain alterations shared by different glioma subtypes. Genes known to involve relevant biologic pathways are highlighted where appropriate, and bolded text indicates a strong association with multiple subtypes in multivariate analysis. 11 SNPs have been associated with increased risk of glioblastoma, 19 SNPs associated with increased risk of other gliomas, and 5 associated SNPs with increased risk of both glioblastoma and non-glioblastoma gliomas. SNP 8q24 has the strongest relative risk, with a 6-fold increased risk for developing an IDH mutant glioma. Though these risk SNPs appear relatively high, given low lifetime glioma risk, they will not be useful for population screening, though may be useful in certain clinical contexts. As with glioma, familial syndromes associated with meningioma risk and other CNS tumor risks are rare and account for a small proportion of cases. In neurofibromatosis type 1, type 2, and schwannomatosis, there is an increased risk of developing meningiomas as well as other primary CNS tumor types and peripheral tumor types. Other familial syndromes increase the risk of development for medulloblastomas. Two more commonly occurring SNPs increase the relative risk for meningioma by a small amount, MLLT10 and RIC6. Here are discussed environmental, demographic, and developmental risk factors for glioma development. The strongest environmental risk factor for development of glioma is high-dose radiation exposure, but this accounts for a very small proportion of cases. Atopic conditions, such as allergies, asthma, have been consistently associated with a decreased risk of glioma, though the mechanisms are yet unknown. And of note, there is no conclusive evidence at this time that cell phone use increases risk of developing a primary brain tumor. Similar to glioma, the strongest risk factor for development of meningioma includes high-dose radiation exposure, again, but only a small proportion of cases. There has also been an association with meningioma and vestibular schwannoma development by dental radiographs. Higher BMI and female hormonal characteristics are associated with increased risk of meningioma. And atopic conditions have also been consistently associated with a decreased risk of meningioma, though again, the mechanism is not yet known. And there is no associated risk with development of meningiomas and cell phone use.